Hello, my name is Sarah Fortune, and I am a nursing student. We are doing a project in microbiology, and I chose bacterial endocarditis. And I chose this topic because my daughter was born with a congenital heart defect, so I just usually find anything that has to do with the heart a little interesting. So again, this is about bacterial endocarditis. What is bacterial endocarditis? It's an infection of the endocardial surface of the heart. It involves the heart valves and it occurs on the endocardium or intracardiac devices. There are two types, acute endocarditis and subacute endocarditis. Acute endocarditis is a febrile illness that rapidly damages cardiac structures and spreads hematogenously, which can progress to death with weeks if it is not treated. Subacute endocarditis has a slower disease process and may be present for weeks to months with gradual progression and less complicated by major embolic event or ruptured structures. There are many causes. I am probably not going to name all of these because I will not pronounce them right. But most of your causes are going to be caused by several organisms. Let's see. Staphylococcus aureus, coagulus negative staphylococci, and there are a bunch, but I am not going to be able to pronounce these. There are some rarer organisms, and they are going to include polymicrobial organisms, gram-negative bacilli, the candida, and the pneumococci. So there are a lot of different risk factors, and greater than 60 years old, males, injection drug use, history of prior infective endocarditis, dental procedures. So before a dental procedure, you typically will take a couple antibiotics just to prevent any infection during any kind of procedure. Prosthetic valve or intracardiac devices, history of valvular disease and rheumatic heart disease. Mitral valve prolapse, mitral regurgitation, aortic valve disease, congenital heart disease, indwelling intravenous catheter, ventricular septal defect, and hemodialysis patients also. These organisms enter the bloodstream from the skin, mucous surfaces, infected sites. They adhere to non-bacterial thrombus due to valvular damage or turbulent blood flow. In the absence of host defense, these organisms are allowed to proliferate, forming small colonies and shed to the bloodstreams. The left-sided infection is much more common than a right-sided infection, except for those that have a lot of intravenous drug uses. So symptoms include fever, which is the most common, chills, night sweats, anorexia, weight loss, loss of appetite, headaches, abdominal pain, and coughs. The cardiac murmurs are observed in about 85% of all patients, and then congenital heart defects and congestive heart failure develops in 30% to 40% of all patients, usually due to valvular dysfunction. Other signs include petechiae or splinter hemorrhages, non-blanching linear reddish-brown lesions under the nail beds. And the ways to find these are blood cultures, laboratory findings, diagnostic imaging. And on the blood cultures, there's going to be at least 3 different cultures. So you should obtain from separate venipuncture sites before starting antibiotic therapy. If culture remains negative after 48 to 72 hours, 2 or 3 additional blood cultures should also be obtained. Diagnostic imaging, echocardiograms, transthoracic echocardiograph, which is also known as the TTE, and the transesophageal echocardiograph, known as the T, which the T also has a higher sensitivity than the TTE, and it's better for detecting any kind of cardiac complications. So treatment, you're going to have your antibiotic therapy, usually vancomycin or gentamicin. The amount of time depends on the pathogen and the site of the infection. The duration of the therapy should be counted from the first day of the negative blood culture. And then usually you are on treatment for up to 6 weeks. Again, it's just depending on, I think, how bad the infection is. And then this is my resource that I got my information from. And this concludes my topic on bacterial endocarditis.